Welcome everyone, good afternoon. I recognize that we've had more interest, which is absolutely wonderful, than we have chairs in the room. Please listen to our colleagues on the staff, Scott and his team. They will determine if the number of people can be accommodated or not. And I'm really apologizing, I'm not sure they can hear me to those outside, but we are recording this as I'm told, so at some point this will be available. So again, bearing your patience, please find a chair and make sure you have a spot to sit down. And if you don't, where's Alan and Tracy? If you can just raise your hands. There's Tracy and Alan here. If you have any issues, please contact them. Okay, so welcome everyone. It's my great pleasure to welcome all of you to this seminar today. And this seminar is quite wonderful, not only because it's a seminar which is a regular seminar hosted by the Berman Institute of Bioethics here at Johns Hopkins, but it is being done in collaboration with the Department of International Health at the Johns Hopkins Bloomberg School of Public Health, and is even made more laudable because it's our 100 years of the School of Public Health celebration. And in fact, I think this seminar kickstarts our month-long celebrations in international health. So first, congratulations to the school for touching 100. An amazing feat. Many of us will not make it there, but those who do, I hope they will enjoy the fruits of getting there. It's my great pleasure because I have homes in both of these institutions, the School of Public Health, where my primary appointment is located, and of course the Berman Institute, where I spend a lot of my time and have close friends and colleagues. So it's a great pleasure to moderate today's exciting session. And as you know, we hope to be talking about international health and ethics and confronting some of our emerging challenges. We have a lovely set of speakers for you today. Some of you, I hope all of them are actually familiar to you, and I will be introducing them as I call upon them to speak. But I wanted to set the stage by acknowledging, first of all, that the history between international health and ethics is really hand in glove. The pursuit of international health at the Johns Hopkins Bloomberg School of Public Health, which started nearly 51 years ago, is really a story of two fingers side by side. It's a story where every individual who actually started our department was intrinsically and acutely aware of the ethical issues that go about in doing public health work in other settings, outside the borders of this country. And in fact, as I was reflecting on this, one of the founders of our Department of International Health, Professor Carl Taylor, the late Professor Carl Taylor, was acutely aware of this. And nearly 24 years ago, in 1992, published a paper on surveillance for equity in primary healthcare. And in this seminal paper, where he talked about the policy implications from international experience, Dr. Taylor said, "Equity in distribution of healthcare is a generally desired but elusive ethical norm. Equity is not only morally right, but it can also help make primary healthcare effective and efficient." Very important words to the core of the founding of our department. And in fact, this year, 1992, was quite important for bioethics as well, because it was in 1992 that the executive director of the Bioethics Institute, Professor Ruth Faden, who unfortunately could not be here today, also published a paper in the New England Journal of Medicine, in which he talked about research and informed consent in Africa, another look. And at that time, people were questioning, do we need to apply research ethics principles outside the borders of the US? And she and her co-author wrote, "Such an obligation expresses important and basic moral values that are universally acceptable regardless of variations in cultural practice." Something that is still being debated today. And of course, I wish Dr. Faden had been here, but I know she's here in spirit with us and looking forward to an engaging dialogue. I will request your permission to spend just a minute on a personal reflection. The story of international health and bioethics came to me actually nearly 20 years ago now in 1997. And two things happened in 97 for me. First, one of my very first papers were published. And it so happened that as I checked on the weekend, in fact, my very first paper was titled Ethics, Equity, and Renewal of WHO's Health for All Strategy. For those of you in the room who are more than at least 25 years old, you might remember Health for All by the year 2000, which was a tremendous slogan for WHO. And I was honored to publish this with Professor Jack Bryant, whom some of you know led CEOMS. And in the same year, I got a call from Professor Ruth Faden. The HIV/AIDS clinical trial debate had broken out, and she called me and said, I've heard you're interested in these issues. You're from the developing world. How about we get together and teach a seminar course on ethics of research trials in developing countries? That course has now morphed, and actually Professor Mariah Merritt teaches a better version of that course now, but it has survived over the years. So that's a personal reflection on today, but I'm really, really excited that the two worlds are going to once again be an exciting conversation today. And as we turn towards speakers, I wanted to at least raise some questions for us to think about. A question around, look at the diversity of topics that we cover on the research side, but also on the public health side. It is not possible in a seminar to cover these topics. There are courses and degrees on this. And so obviously, for those of you in the room, you might want to raise some of these issues, but we may not be able to cover all of them. And yet, I hope that we will explore some key issues like, is ethics and ethical sensitivity intrinsic to the way international health is conducted and done? Very importantly, is it key for those of us in international health, including organizations, to be constantly cognizant of and keep up to pace with ethics issues? And I hope Professor Peters will touch upon some of the emerging challenges that have come to bear. And then very importantly, I know for at least half the audience, how can we train our future leaders in international health to be role models, not only in research ethics, but also in public health ethics? And I hope that we will have a great dialogue in the ensuing few minutes. It's my great pleasure first to welcome Professor Nancy Cass. Dr. Cass, for those of you who don't know, is the Deputy Director for Public Health for the Berman Institute of Bioethics. She's also Professor of Health Policy and Management. But most importantly of all, Nancy has been a great friend, colleague, and mentor, and she is absolutely one of the most genuinely, humanely caring persons in the world. So I welcome Nancy Cass.
Great. Well, thank you, Adnan, and thank you to all of you who are here under tight quarters, and apologies to the people who couldn't get in. Those of you who work in my building, in Deering Hall for the Berman Institute, know that we were already excluded this morning when there was a gas leak, so I really felt badly for the people who were turned away this morning and turned away at lunchtime, and hopefully they'll be welcomed somewhere this afternoon. So, okay, so I'm going to, Alan, is this also on? Can I wander if I want to? I know, but if I want to walk around.
Just turn the switch on.
Okay. Great. Good? People can still hear me? Excellent. Okay, so I'm going to try in 15 minutes or less to give you an overview of how our thinking about international research ethics, I think, has gone through some stages, and then try to at least plant the seed for a couple issues that I think are not only still on the radar screen, but potentially emerging. So I am roughly lumping the way we have thought about international research ethics, with the caveat that this is generalizations, right? And that people can poke holes in every piece of this, and I can find exceptions too. But writ large, it's my own sense that when people started to think about international research ethics before and in the 1980s, the primary focus of those kinds of questions and papers was on cultural relativism versus universalism. Bioethics really was emerging in the 1960s, 1970s in the United States, certainly around research ethics. We got our federal regulations in the 1970s. And as we start to develop this sort of common morality in the United States around research ethics, can that be exported? Ought it to be exported? And even if it were going to be exported, what does that mean in terms of application in a local setting? So I'm going to call that sort of maybe the era of thinking about respect and what that means. Era 2, maybe 10 years later plus, was research ethics and study design. And you'll see on a later slide, it's where I say bioethics discovers epidemiology. And I'll talk a little bit more about that, but that focus was certainly on justice to some degree, but also significantly on beneficence. If we say in research ethics that we need to think about the risks and benefits to study populations, how can the study design affect that, and what kinds of study designs are ethically acceptable? So not just thinking about cultural acceptability and consent, but then really thinking about study design. And then era 3, research ethics really is thinking about justice issues, which arguably are the hardest and are always going to be the most sustained until we have a very different model of the way the world works. Okay, so era number 1. Sorry, I'm going to move back here because otherwise I'm going to get a funny crook in my neck. So is individual consent the ethically right approach in environments where one-on-one dialogue to make decisions is arguably less the norm? And I also, cite the same paper that Adnan put up by Ruth Faden and Carl Eiselmuden. Carl Eiselmuden is a South African physician and researcher who came to do a postdoctoral fellowship with Ruth, expressly because he came here thinking he wanted to write a paper on why community-oriented consent. He never thought that consent should be thrown out the window, but he came here really with the idea that consent should be communal, because that was much more the norm, the cultural norm of decision-making in Africa. And by the end of a lot of reading and discussion and thinking, ended up thinking that individual consent must be sustained. And I certainly recommend to anyone interested in this territory to read the paper by Carl and Ruth that was written a while ago. Our colleague Godfrey Tangwa from Cameroon wrote a couple of really remarkable papers, some of which I still assign for my coursework, on the African notion of personhood and what that means for the notion of respect, and then really for research ethics. Ruth Macklin, our dear bioethics colleague from Albert Einstein in New York, whom I credit with being one of the bioethicists first engaged in international research ethics, wrote a book on cultural relativism. So really taking on this question of, is personhood viewed differently in different cultures, taking on gender questions: can husbands consent for their wives? How can researchers explain research to people who don't have words for research, don't have words for placebo, where the understanding about how you get something like malaria or HIV is based on a really different set of beliefs? And so those kinds of challenges that significantly had to do with differences in cultural norms, often between the researchers and the people who were being invited to be part of studies, and also around consent. Okay, so era 2, and again, I'm going to echo a little bit what Adnan was starting to allude to in his introduction about the AZT trials. So I'm going to really not do justice to what this debate was about. Can I just see a show of hands of people who have heard of the AZT perinatal debates? So I would say about half the room. I will still say it's one of these moments that makes me feel old. In my own class that I teach on research ethics, I say, the AZT debates, and people look at me like I'm from Mars. And I tend to think it's part of our lexicon because so many of us lived through this as a sentinel event in bioethics and international research ethics. So I'm going to try to get us on the same page in less than a minute. Think back or imagine back to when HIV was starting to be epidemic, both in the United States and globally. There was nothing known to prevent transmission other than condoms. And a study was done in the United States and in France whereby pregnant HIV-infected women were given what was sort of called this cannonball approach to AZT, which was the only antiretroviral on the market at that time. We had one drug for treating people with HIV. So this AZT antiretroviral was given to pregnant women starting in the fourth month of their pregnancy in the US trials. And the women got AZT drip intravenously during labor and delivery, and the babies got AZT by mouth for the first 6 weeks of birth. So that was the intervention. And people in these trials in the United States and France either got this sort of mega 3-part intervention or placebo to test this wild concept that if you gave people who were HIV infected a medicine, maybe there was less chance that, in this case, their offspring, or now we've later learned their partners, that other people would be infected, that essentially if you reduce my viral load, am I less infectious to you, in this case, my developing baby? It turns out that these trials in the United States showed that, yes, it did make a big difference, and yet this intervention was really complicated. It was very expensive, but money was not the only piece. It assumed that people were coming in for prenatal care in the 4th month so that they could start on this medicine, and that they had access to a hospital delivery with intravenous supplies for every delivery, which was not going to be the reality in most of the developing world. So this big meeting happened in Geneva. A consensus group said, we have to test in the developing world interventions that are much more accessible, lower cost, and easier to implement. And so many studies were designed. The group in Geneva, which included people from all over the globe, said make them placebo-controlled trials so that we can figure out whether, for example, giving women a 3 or 4 week dose of AZT at the end of their pregnancy will make a difference for them as well. After these studies started to be conducted, and 16 of them were planned, there were accusations from Public Citizen, a nonprofit advocacy group in the United States, saying these trials were unethical. Now that we had an intervention that was given to women across the United States that would help reduce the chance that their babies would be infected, how can we do a placebo-controlled trial in Africa or in South America or in South Asia? And there was really an enormous debate. Some of the trials went on, some of the trials were stopped. I won't say more about that for the sake of time, but it was really, I think, the sentinel event that got so many people in the bioethics community, who at least in the United States had mostly been focusing on issues within the United States, to think about international ethics. And arguably, a lot of people in international health began to think about this tension in ethics, which is one that they face all the time, because they go to the global south to try a new intervention. I mean, think even of one of the most groundbreaking discoveries of oral rehydration. One can argue that that's only relevant because people don't have access to safe water, and really the right thing is to get them access to safe water. So much of the work that is done in international health begs this question about when you're trying a new intervention, do you do it in the context of the injustice and lack of access to things we know work in the community where you want to test it and eventually apply it? Or do you need to be able to offer people the kind of care that they would have received in the United States and Europe? Sort of in the footsteps of what we're doing now in so many of the big symposia that the School of Public Health puts on around Ebola and Zika and things like that, there was a symposium that our dean then, Al Somer, called together to raise these questions in '97. The Declaration of Helsinki, which is one of the sort of landmark global bioethics, research ethics guidelines to which we still refer. International journals still say papers that have to, papers to be published in their journals have to be in alignment with the Declaration of Helsinki, a very living document. Interestingly, was turned to by both sides in this AZT debate, saying, see, the Declaration of Helsinki validates my point of view. The Declaration of Helsinki says, if you're going to do research, and you're going to do research in a randomized way, you have to provide the participants in the study with the best available care. So the people who were arguing for the placebo-controlled trials, when these trials were done, let's say in Africa in the late 1990s, and half the women got, let's say, 4 weeks of AZT and half the women got placebo, the people looking at this side, one point of view said, we're giving them the best available care that they would have gotten. Nobody's being denied anything, and half the women get something better than they would have gotten. And people on the other side of the argument said, best available care according to Helsinki means best anywhere in the world. And it was clear that Helsinki was ambiguous because when it was written in 1964, nobody was thinking about global injustice. And there have, for those of you who follow this arena, there have been multiple proposed revisions to the Declaration. There have been revisions to the Declaration, but this is a completely unresolved issue. Let me skip over that and keep going. There were many other bioethics commissions, both within the United States, what was called NBAC, the National Bioethics Advisory Commission, with whom Adnan and I both worked on these issues, the Nuffield Council in England, bioethics commissions around the world were taking on this question: what does it mean to do research in low and middle income countries in an ethical way? And again, arguably, all of this was prompted by the international debates. And again, New England Journal articles, studies being stopped, et cetera, because of this question about when can you use placebos when you go to an environment where people have no access to the kinds of healthcare that you're testing. At the same time, it became clear to many people who were observing what was going on that these rancorous debates that were occurring were primarily occurring really significantly between Americans. And again, there was some involvement in Europe. But when there were voices being quoted in the New York Times or in the New England Journal, they were significantly of people from the global north debating with each other about whether using a placebo in this kind of context was acceptable. At the time, the Fogarty International Center, which is a very small piece of the NIH with which people may not be familiar, but whose mission primarily is to train people from the global south to be collaborators on NIH research projects, so that projects don't have to be simply people from the United States going to a low-income country, doing research and leaving, but instead can have genuine partners. The Fogarty International Center and their relatively new director at the time, Jerry Kirsch, said, we need to free up a pot of money for bioethics. And they did that in the year 2000 for the very first time and had targeted programs devoted to training people from low and middle income countries in bioethics so that they could be part of the conversation to help resolve these issues. In 2001, the first 5 programs were funded, and now there are 22 programs, 7 of which have LMIC directors. So the third era is arguably one of justice. And again, you can't help but think of justice in any of the issues that I've discussed, that Adnan discussed, I'm sure that David will discuss. But some of the kinds of questions that were emerging in what I'll call this third era were much more expressly around justice. This, particularly before the Gates Foundation got involved in their big more recent set of funding initiatives, there was a lot of attention to this thing called the 1090 gap. That 10% of our global research budget was spent on the illnesses that affected 90% of the global population. That alternatively, we're spending 90% of our budget on the kinds of diseases that only 10% of the globe gets. Also, a lot of questions about what happens when studies are over. You test these HIV drugs, and you learn that some of them make a difference. But where is it in research ethics that we say that people who were in the communities where the studies were tested have to get access to it? We have a research ethics infrastructure that's designed to protect the participants in the research. And there's this implicit assumption that if we learn that something works, it will then happen. It will then become available. Obviously, there's so much attention now to implementation research to learn how to do it, but also this notion was raised, do researchers themselves have an obligation to work with international donor agencies, to work with local governments? And should we in the ethics community, should an IRB not even allow a study to go forward if it's not clear that something will be made available afterwards? Again, huge debates on this, because experienced researchers were saying, if I need to have a contract saying my new vaccine or drug will be put into place when I'm done with the study, before you even let me start, I'm dead on arrival, right? Almost no ministry will do that, and arguably they shouldn't, because they need to see how good it is, and we need to see if it's replicated, and we need to see where that fits with their other national priorities. But at the same time, if we have no attention to what's going to happen afterwards, then research is done for research's sake, and that's not really getting public health any better. So a lot of ins and outs about that discussion and how do we figure out what that means. There was also really interesting discussion in the ethics literature about whether being fair to the populations who took part in research had to manifest itself only in terms of getting access to the drug being tested. A whole group at the NIH, of which Mariah was a part, put out a different kind of approach talking about fair benefits. Yes, you were part of that? You were part of an ancillary care one. Implicitly, right. And sort of taking on the question of maybe what is fair to a community that takes part, particularly if we can't guarantee access, but maybe even if we could, is to learn from them what they want most. Maybe what they want is a cleaned up water supply. And maybe in exchange for testing an HIV drug, they get a cleaned up water supply. And again, raising all sorts of really interesting questions that arguably have been unresolved but relate to this question of justice. Questions of ancillary care, meaning if someone is in your study and they have no other access to health care, and let's say it's an HIV study, but they come in with an infected foot, what's your duty as a researcher? And when the first person walks in, you sort of feel like, okay, I've got a nurse here, let me help you. And then when word gets out in the community that you're acting like a health clinic as well as a research study, there are hundreds of people at your door. And all of these problems exist only because of global injustice. They only exist because the right answer is that everybody should have access to a clinic. But when they don't, and the research community comes into town, the researchers are somehow handed this whole plate of global injustice to try to navigate themselves. So there also have been some arguments, and I have to sort of do a shout out to Ruth Faden and some of the work that she's done with her colleague Madison Powers to think about research questions that themselves can have a voice in addressing injustice. So for example, and highlighting this idea that there's moral relevance to the research questions that we choose. That's in a meta sense, that was what the 1090 gap criticism was about. But even more narrowly, when we take on research questions that even in a low-income country address the needs of women or pregnant women or LGBTQ communities or refugees, or questions that are related to the well-being of people affected, including in health, we are thinking mindfully about justice. So unanswered questions, I want to underscore that all the things that have been part of these era have not been worked out. Adnan and I have been running our own Fogarty program for 17 years, and I would say that the concerns we get on our applications over and over again have to do with informed consent and what's the right way to do it. And here we are in 2016, and that's still a challenge. Standard of care questions are unresolved. Much more attention to community engagement. And I think intuitively we get a sense that that's a good thing to do. It's a way of demonstrating respect on a community level, but it's not exactly clear why we do it, how we do it, with whom we do it, who should do it. Justice issues, again, are rampant. And I guess the last thing that I'll say, just as another kind of example, there are more and more social policy experiments happening both in the United States and globally. There was a big op-ed about them in the Sunday Times. And as we go to various places and say, what's it like to give you your schoolgirls uniforms and your schoolgirls money? And we do this, sort of on a village by village or national basis. How does our old model of research ethics fit in? So I guess I'm going to stop by saying, who knows what the right answers are, but it sure pays to invest in people, and we have to carry on this commitment to investing in people who live in these places and not only having these debates at Johns Hopkins. And here is, in that spirit, just one shot of the reunion we had of our Fogarty program last year, with a particular shout out to my colleague Adnan. So I'll stop there. Thank you, and we can go on to David.
Thank you very much, Nancy. As usual, an incredible summary of what has occurred in 40 or 50 years, and only Nancy could have put that so well in 15 minutes. So it's my now great pleasure to welcome Professor David Peters. Many of you already know David. David is the chairman of international health here in the School of Public Health. Of course, David, like actually Nancy and like myself, is an alumnus of the school. So it's a great pleasure also because it's our 100 years of always welcoming alumni back, and in some ways we never left. David, of course, not only has spent time at the school, but also has worked at the World Bank for many years, both at headquarter level as well as country level, and has a tremendous wealth of experience in health systems and is considered one of the leading health systems researchers in the world right now. But more importantly for us, is also an incredibly democratic and open-minded leader for us. So welcome, David.
Not sure what that means. Thanks very much, Adnan. That's very generous. I want to spend a few minutes talking about health inequities because it is so important in global health. Talk a bit about, I think, what we should have been learning over the last, we've been in this for 55 years as a department, as the first academic program, and then maybe provoke a little bit about some of the continuing challenges and where we want to go. And I start off with this picture because it really shows some of the inequities. This is a pictogram that gives the size of the country according to infant mortality, and you can see where it's concentrated. If you now look at where global health spending occurs, the picture is exact opposite almost in terms of where the infant mortality is. It's a very graphic way of showing us the kind of inequities that stare us in the face. And just to be clear, when we talk about health inequities or inequities in general, we've been looking at this not just in terms of are there differences and are things equal or unequal, but really the notion that there's some unfairness and injustice about the causes or the manifestations of these inequalities. And if you look back at the reasons why our department was started in the first place, it was really about the words they used at that point in the early 60s was about social justice. And I think that legacy is still an important part of what we do. Now, it could be argued that we are in a new era. In 2016, we finished the Millennium Development Goals. We're now into the Sustainable Development Goals. An interesting thing to note about the MDGs is that they really didn't talk about inequities. 3 of the 7 were directly health-related of the goals. And they talked about aggregate levels and improving services and outcomes, but not explicitly about inequities. The social development goals, not only are there more of them, they really take on the notion of inequities. In fact, one of them is about inequities, addressing inequities, another one about gender inequities, and even the other things are about inequities in services. So even about health, a lot of it is about trying to improve universal access to care, for example. So equities is coming back into focus again, as is trying to find ways of linking different parts of development. Now, one of the prevailing ways or models of looking at inequities comes from the Commission on Social Determinants of Health, and this is the social determinants of health, and you can see that this is a pretty thoughtful type of way of looking at what health and well-being, coming from a sort of the organization, the broad political, social, economic environment, some of the aspects related to individual and group characteristics, and then different kinds of circumstances, these related to sort of the theories of how people actually become impoverished, leading to health inequities. And so this has become a prevailing way of looking at health inequities, although I have to say that the social determinants are still sort of a weak cousin, if you will, in terms of other areas of health research inquiry. But it's also a little bit simplistic. And here, just to take one particular part, we realize these are not linear relationships between these things. And here you see, a typical type of vicious cycles between poverty, nutrition, exposure, and ill health. And they all tend to be reinforcing feedback loops. In other words, they cause cascades, and ways of breaking out of them are different, in that it really means looking at things in a much more different way than just sort of linear pathway. But we also know that we've been looking at inequities for a long time. And in the 1990s, it became quite common to start looking at the differences between the rich and the poor. And here you see, over 55, I can't see, 56 countries. These are different regions of the world, and you're looking at the infant mortality between the poorest 20% and the richest 20%. And pretty well everywhere around the world, you see these pervasive and entrenched inequities in terms of health outcomes. So this is sort of one of the key areas in which we're dealing. Now, again, we've been looking at trying to address inequities since the beginning of International Health Department. But here's some assumptions that have gone into this field as the field has developed. First of all, the notion that health inequities, they don't correct themselves by themselves. They actually do require interventions, and these are the policies and programs that we use to address them. There is this prevailing thought, though, that if you work in poor countries and poor locations in countries, you're going to be able to reduce inequities. If you can develop low-cost, affordable solutions, these will also help reduce inequities. Maybe ICT, communication technology, are part of them. I don't know, but anyways, low-cost solutions. The other notion is that once you have a strategy and interventions, you're able to replicate them and potentially at scale, and that because of this, we have pretty good idea of how to do things. You don't really need comparative evidence to demonstrate that there are changes in inequities. Now, of course, you know where this is heading because the latter is certainly not the case. And some of the work we did now for the last 15 years has looked at inequities. So if we're talking about universal health care, this is a spider diagram looking at 6 primary care interventions that should be universal. And looking at poor to rich ratios, they should all be at 1 if we were to achieve universal coverage. And what you notice about them is that they never achieve 1, but that they're also not the same across regions of the world or across different kinds of services. So this suggests, well, maybe there's something here other than some natural law about inequities, but certainly inequities in service provision are persistent. Now, even if there isn't a natural law, this hasn't stopped people from calling one, because in fact Hart's law, which I think was first articulated in the 70s, is about this notion that when you start a new program in health, it's the better off that are going to benefit first. And this is looking at some work from Cesar Victoria, who's done really good work on inequities. And they had this program on undernutrition in Brazil. And as you can see from 1987, this is a concentration curve. If it were equitable, it would be along that center line. As it moves up to the left, it becomes more inequitable. And what you see here is as they created a program that actually improved nutrition services, they actually increased relative inequity during that time. Another case, I'm going to talk briefly about India, where I spent some time, because India was one of the countries that had one of the most pro-poor rhetorics in its policy, more broadly, and that's a picture of Ambedkar and Gandhi, for those of you who don't know. But what we did for about 5 years around the turn of the millennium was actually to look at how this was actually playing out in terms of health systems and services and health outcomes. And that's 2 of the publications. So one of the first things we did was we looked at where is the public subsidy in health going? And what we saw here is when we looked at public spending in health, the poorest quintile was getting less than 1/3 the public subsidy than the richest quintile. This despite all this pro-poor rhetoric, all the programs that were in place intended to reach the poor. And this was true across almost all, we did this across the country. There was 1 or 2 states that were close to equity, but overall, most of the states were very, very inequitable, and nationwide it was quite inequitable. If we then looked at different kinds of services, this is a concentration curve again. Just to cut to the chase, what you see here is inpatient hospital and outpatient hospital are more inequitable in terms of the rich actually taking more of it than the poor, and these immunization and primary healthcare services tended to be relatively more pro-poor in their approach. But again, different services are capturing different kinds of benefits. And as you can imagine from this, most of the money was actually going into hospital care and most of the public sector money. And hence, that's what led to that kind of inequity in public subsidy. We also found that just going to the hospital, public or private, led to falling into poverty. And here you see, that overall, nearly 1/4 of people, if you went to hospital, you would fall into poverty as a result of that. Now, these were 3 parts of a very large study, but 3 parts that were cited as India then moved into the Rural Health Mission as a basis for doing the Rural Health Mission, which has really dominated much of the policy and practice in public sector in India for the last 5 to 10 years. And now it's become just the health missions. It's not just rural areas. But as you can see, this in some respect, this actually shamed public officials into actually making a change because now they were being held accountable. Fortunately, public officials were involved in the design and conduct of the study, so that helped a lot. So jumping forward a bit, I think it's useful to know, what should we have, or what we should have learned about, or what we are now learning about addressing health inequities. And this is from a book, Reaching the Poor, that in Health Nutrition Population, that came out a few years, well, maybe let's be 10 years ago now, that was quite good. But one of the first things matter, even despite what I was saying about India's intentions, it still matters. You still need to have intentions and a plan to address the poor or disadvantaged, because if you don't have those intentions, you certainly won't reach there. The other thing that was interesting through a set of studies is that NGOs, although assumed that this is a group, non-governmental organizations, will reach the poor, they frequently don't, despite best intentions. So you can't just assume that having a not-for-profit delivering services will reach the poor. And if you do have pro-poor services, you can't assume that services reach the poor for the right reasons. In many cases, primary health care, public sector, India, were pro-poor because the rich didn't want to go there, and they could afford to bypass services. But what also became clear is that you really do need to measure and verify whether inequities are occurring and if they are being addressed, and that, again, going back to something Nancy was saying about stakeholder engagement from participants to implementers and policymakers was critical. I'm just going to jump forward to another part of inequity and looking at some issues around gender gaps in health. Now, this is a gender analysis. I don't know if you've how commonly this is seen at the school, but the gender gap report comes out from the World Economic Forum, and it looks across a number of parameters of gender gaps around the world. They've been doing this for for 10 years now, I guess. And if you look at this, you'll actually see each one of these dots represents a country. The blue is the average. 1 is perfect equity, and 0 is inequity. And if you look at health compared to other sectors, they would say that we're actually doing pretty well. Because it's much more equitable than, say, political empowerment and participation and economic empowerment, and also better than educational status. And that this is something that's actually been true for a long time, and there hasn't been much change in the health index, whereas the political index, which is not doing so well, at least is going in the right direction, and similarly, slow improvements on health. But I would say that, well, does that mean we're okay in terms of gender inequity in health? And you know the answer is going to be no. And part of the reasons are technical for what they measure, or actually for what they don't measure. Because a gender gap largely looks at healthy life expectancy and sex ratios at birth. And there is obviously a lot more to gender inequity in that. I would also say that what it does miss is that the things that are systematically unsupported and or just plain undermined have to do with sexual and reproductive health rights. There are certainly gaps in empowerment about health services. Interestingly, when we look at in the last 10 years in Afghanistan, we looked at male to female use of non-sexual reproductive health services, and that women actually did use services more. But I would argue that there are differences in quality of care, differences in equity of care that still have some major gender gaps, and I think huge problems in terms of most health systems have a real gender gap in terms of leadership and accountability within their health systems. So I'd argue, it's not that the gender gap isn't looking at things that are important, but there are other issues that still are important. And in fact, if we're now looking at the broader determinants of well-being, some of those political and economic issues are really quite key to improving well-being as well. So, what should we do? What should we be doing? Well, I think some of the things that need to change is moving from our focus on poor countries to disadvantaged people within countries. About not just addressing health problems that affect the poor or disadvantaged populations, but actually reaching out to those poor and disadvantaged populations that are suffering from those conditions and working from the people perspective rather than just on the health problem perspective, as well as, again, using data and learning for accountability. I'm going to close up with just a couple of slides here, but I think that we should actually know a lot about what makes a good pro-poor health reform, at least within the health sector. And some of these have to do with governance and oversight. It's about improving or amplifying the voice of the poor in health. This is about participation and empowerment. It's also about what I've said about measurement and disclosure. This is about accountability. It's about, if you will, what it really means to regulate health systems. There are a number of things you can do with financing about how you raise revenues. Don't punish people for being poor and have them pay more, is the obvious thing. How you allocate and how you make payments, there it does probably make sense to make sure that services are going to the poor. Changes the incentives. Organizational aspects, I think closing the geographic distance, the cultural difference between the poor and services is critical. And if you will, on persuasion side, there's big differences between understanding what's needed and what's demanded among disadvantaged populations. So I'm going to finish with this about some continuing challenges that I think that still face us. So in the first place, I think we still need to better understand both the manifestations and causes of health inequities in all of its complexity. And I think we need to move from models that are ones about determinants to ones that are about systems. Not just health systems, but market systems, political systems, institutions, and social systems. I think that that's a step that we need to be moving towards. The other aspect is, even as social determinants and the social aspects are increasing, I think that we have neglected some of the, what do they call it up here? Changes in the physical environment. Yes, we've always looked at wealth and probably housing to some degree. But increasingly, we're faced with huge differences in terms of populations that are vulnerable because of climate change, because of the built environment, and just plain geography. And we haven't really looked at this in a sufficiently integrative way. I think this is a neglected area. And then if we do look at health inequities from a systems perspective, they would actually qualify as wicked problems, things that are very pervasive, people have different perspectives, a lot of partial solutions. And what that means is actually you need interventions that are sustained. They change over time, but they're sustained. They need to be multi-sectoral and cross-disciplinary. You need to actually find ways of linking what you know in your research to the policy and programs. You do need this engagement of stakeholders, including those in different positions of power and having very different perspectives, both for individuals and community that are disadvantaged. The problem that I see us having we in a university and others involved with research is that our research systems are not set up that way. The funding is not designed for this kind of work. The incentives, with academic incentives, the need to focus within disciplines, and the programmatic approaches is not conducive to the kind of research and practice that would address inequities in a coherent and sustainable way, doing all of these things above here. So at the end, I would say that yes, we need to continue to focus on social justice, keeping our eye on addressing those inequities, and to find creative and new ways to address them in innovative and engaging ways. So thanks very much, Ed.
Thank you very much, David. What a wonderful display of the work that International Health does. That was amazing. So, and I hope that describes the diversity of topics, disciplines, skill sets that we use in International Health. It's my great pleasure to welcome our first discussant, because the second discussant are all of you. And we're delighted that Dr. Mariah Merritt will open up the discussion from the floor with her reflections on what she's heard, but also carry forth her tremendous knowledge from a justice perspective. Dr. Mariah Merritt is an associate professor of international health and bioethics. She's integral to the relationship between ethics and international health, and has been a wonderful 6-7 years ago when Mariah joined our faculty, and has really taken the charge of moving some of these deep level of inquiry that is needed to thoughtfully think through some of these problems. So great pleasure to welcome you, Mariah.
Thank you very much for the generous and warm introduction. Can everyone hear me okay? I'm kind of a low talker. Yeah. So I've been asked to be provocative and to look for some cross-cutting themes in the presentations by Nancy and David, and I'll also be brief because I'm eager to hear what everyone else has to say. First, some common themes. What I'm hearing from both the presentations on international research ethics and global health ethics are the fundamental ethical commitments. Do no harm, respect, protect, and fulfill human rights, bring about good outcomes, seek fairness in the distribution of those outcomes among the people affected, avert and alleviate severe disadvantage, and in any given situation, if all of the above converge, great. If you sometimes face trade-offs among any of those fundamental commitments, then you need to think very hard and in a well-informed way and in a reasonable way about which way to go, so that the people who might lose out as a result of that decision can at least understand it and counteract it in the ways that are open to them. And what that really emphasizes is the importance of situational awareness from the very beginning, and consultation and collaboration with the people that we interact with as health professionals. Specifically with respect to justice, which is a sort of cross-cutting element among most of those considerations, and certainly in bringing them all together, We know that poverty and social exclusion are major determinants of health. And at least in my opinion, and I think there's evidence to back this up, these things are in turn in our world today largely determined by global forces such as the way the financial system operates, the continuing oppression and invisibility of girls and women throughout the world, some places worse than others, the global failure to contain armed conflict, and to respond humanely to the plight of migrants and asylum seekers who are fleeing from those conflicts. The global response to climate disruption. We had a nice hopeful moment in Paris recently. We hope it can continue, but we don't really know what's going to happen with the very planet that we live on. And also, within different parts of the globe, we have local and national, let's say, inadequacies of governments, to use a polite term. Some of us were at the speech by Angela Davis earlier, about a week ago, where she talked about mass incarceration, which disproportionately affects African Americans. Flint, do I need to say more? Maybe we need to look in our own country, in our own cities, too, because we're also on the globe. So these reflections lead me to ask a few questions for everyone to think about. First of all, does it make sense, has it ever made sense, and particularly does it make sense now, to think about health in isolation from financial sectors, defense sectors, criminal justice sectors? Does it make sense to think about the international in isolation from the local? And does it even make sense to think about human health in isolation from the health of the planet and of the non-human animals and plants that we share our world with? So, lest you be overcome by gloom when reflecting on those questions, I wanted to suggest that over the next 100 years, at Hopkins at least, we can take to a new level the collaboration between the Berman Institute and the Department of International Health, and even between those two entities and other schools in the university. Very exciting work is being done in all these areas, and we have colleagues that are right next door. So let's work with them some more.
Thank you very much, Mariah. A great reflection. And now we are open to comments, reflections, and questions. You can make a comment if you're stimulated by what you've heard. You can reflect on your own experiences, or you can ask a direct question. And I'm going to let 2 or 3 comments go, and then maybe ask for our panelists to respond as well. We have several minutes. Alan is here. He's got a microphone. Make sure you raise your hand. So our first question, yes.
I'd just like to thank the group and propose that Mariah throw her hat into the presidential race with that.
Mariah, you've been nominated for presidential election. So your next debate, Trump versus Mariah Merritt. Yes, please.
Good afternoon, and thank you to the panelists and the discussants. I'm curious what you comment about the role and the potential and the power that an institution such as Johns Hopkins University, one of the oldest schools of public health in the world, can have on that particular piece of the structural challenges of the way that research operates that won't allow us to engage necessarily in these more sustainable ways. The research questions have to be posed before the research even begins, that people, to be able to continue to do the work that they want, have to work within disciplines and within bounds, and also that there's a very specific power dynamic that's developed when funds follow researchers. It can sometimes be at odds with governments, it can sometimes be at odds with persons that you are engaging in this research with, or sometimes you are researching in sort of the worst version of how it operates. So what role can an institution like Hopkins play in shifting that?
Great question. Let me see if there's another question or two in the audience right now. Yes, please.
Thank you for the talk today. I think maybe on a more hopeful note, I was wondering if there have been stories of success, either related to research ethics or, promoting equity in public health in your recent years in your work over the past maybe decade or more. Has there been country examples where there has been more public health equity that's been sort of, slowly edging its way up? And in terms of research, maybe more successful research plans have happened.
Yeah.
There's been an uptake of that research and more equitable exchange between the researcher and communities being researched.
Good question. Very important for our potential donors also. What are your successes? Have you succeeded? Any other question from any other? We've got a hand right there, and then we'll go back to...
Thank you for organizing this Saturday. This is important for us. So, before I ask my question, allow me to talk about two incidences so that my question is better understood.
Briefly, yeah?
Yes.
Not another speech, huh?
Yes, no worries. I have a very ethical question. So, last year I went back to my country to do the election. So I was working with a national NGO, and they have 7 different sites across the country. So three sites of the election in, and I got a call from the head of the organization saying that, what are your findings, and can you tell what is happening with the election, and did you find anything interesting yet before the end of the election? That was incident 1. Incident 2 is that, so I went to a seminar last week, and we talked about sharing different results in a multi-country study. So I understand and accept that the ultimate aim of our studies are to make implementations better. And it's not ethical not to share the results, but there are so many limitations that can happen with sharing different results. So if I could draw on your expertise and your African understandings and opinions for sharing interim results.
Very important question. Yeah.
We should be thinking about.
Yeah, great question about sharing results and also the right time to share results. So let's take those 3 and let me go from one end to the other. Maybe I'll start with Nancy and move towards Mariah and see if you have reflections on any one of the 3.
Okay, is this on?
Yes.
Yes, way to go, David. This is partnership, right on real life. So I'm just going to pick up on a couple of pieces because there were some that I think David is much better situated to answer. So I love the question about what can Hopkins do. And I'll start by saying I don't know, and I mean that genuinely. In the research world and in the global health world, Hopkins actually is a big player. And there are at least some individuals in the global health and global health research space where where individual Hopkins faculty are big players. And it seems like in any environment where someone has power, has voice, and you see it when, Bono goes and does a concert on behalf of something that he cares about as a social cause. When you have power, you really can get access to decision makers. And again, I don't mean to over-glorify the access that people at Hopkins have, but there are some people who have access to important people. And even in things like you start with research, there are aspects of how the NIH has changed, at least some components, some ways that it does research, that really have changed in response to people talking to them. Sometimes about the agenda, again, narrowly from the kind of things I think about, there's funding for ethics and there didn't used to be. There's funding for ethics in international research and there didn't used to be. There's funding for research on pregnant women and there didn't used to be. And the things that people think of as important and were raised as sort of justice questions, injustice questions, even things like at the beginning when there needed to be a faster track for HIV research. So there are human beings in charge of all these things, and sometimes you can get access to this. There's also arguably, when you have a lot, it's this whole awkwardness when you kind of move a lot of money to another site, and there's no getting around it. But trying to figure out ways, to almost ask oneself that question in the context of an individual project about how can I listen, how can I reach out, who are going to be my partners who can help me really understand what people are thinking and not only sort of just like sucking up to the people with money, is, I just think, an important exercise. It's like an exercise in humility. It's something that individual researchers, particularly in the projects.
So I'll follow up on the same question actually, because I think that it's hard to have a specific, again, single intervention to change the structures around to how we can do the type of research that's needed. And so first of all, I think that we shouldn't neglect the fact that sometimes it is important to actually do research that involves looking at a microscope and is very focused. That's not really the, I don't want to say that that's not ever relevant. But I think in terms of addressing these complex problems, we need to find ways in which we can encourage and stimulate more cross-disciplinary kind of work, the kind of work that gets us out of our comfort zone and engages our people that we tend to work with overseas, for example, and not just other researchers, but the communities in which they work. I think we need to find ways to build in multidisciplinary work, and at this time, it probably means doing a lot, little by little, and taking small steps. I think that this university has been quite at the leading edge in terms of promoting the scholarship of practice and policy and practice influence compared to other universities, at least trying to reward faculty for doing that. It's a slow process. Universities are some of the oldest institutions, and they're slow to move, but they're also relatively stable. Unfortunately, our model is very much dependent on soft money, and so our ability to fund research, our change of funding, I think, is more of an indirect route. I think Nancy's mentioned that that some changes have occurred, but I'm not sure we're gonna. I think it's sort of going to be an ongoing set of challenges, but that we should be doing this explicitly and trying to use some of the resources that we can, which are basically people's time, effort, and money if we can. In terms of, are there examples in terms of improving equity? There are lots of examples. In fact, that book on reaching the poor is a book full of good examples. And some of the things that we've learned, for example, even in India, you looked at that spread of inequity of public subsidies. That's a national average. On the other hand, Kerala and Gujarat are two states that were able to actually be close to equity. So they were doing something right. They had much more of a pro-poor policy, and they changed demand actually for services. Some of the things that we've done, one of our colleagues here, Krishna Rao, has a chapter in that book, for example, on improving quality of services with a focus on equity. But the things that keep coming up are, you have to say that you're trying to improve equity. You have to measure it and disclose it. And then you need to engage people that are involved in making the changes. So those were sort of the three formulas that come out of those examples. But there are examples around the world where that can be done. Again, they tend to be medium to short-term projects, and what we need are really to get at some of the the more entrenched and intergenerational types of issues of inequity require a much longer and sustained and evolving approach. So I'll pass it on to Mariah.
Thanks. So,
We have your own?
yeah. Thank you. Well, we may need to come back to the question about interim findings, because that is important, and I don't right now have anything in particular to say about it. I just wanted to address the question about what role can Hopkins play in shifting the dynamics that are plaguing the world. And I think about the fact that we are essentially a research university, and it's part of the university's mission to cultivate lifelong learning in all of our students. And my feeling is that, again, over the next 100 years, and sooner rather than later, like next month, next year, it would be good to energize further our vision of what the world can do with the talent and the commitment and the knowledge and the network of all of our students and alumni. And we, while we're lucky enough to have our trainees here with us before you all go back to the different places where you might have come here from, we need to embrace the opportunity to learn from the experiences that our trainees bring to us. So those are just some feelings that I have about that question.
Thank you very much to all three of you. Actually, I was hoping to entertain another round of questions, but I've just been informed that we need to probably wind down. So if you have questions, please email us, as well as just as soon as I end, we'll have a few minutes here in case you want to run up and talk to one of our panelists here. I just want to say it's been a tremendous opportunity for us simply to highlight the close working relationship between not only two parts of the same university, which is the Berman Institute of Bioethics and the Department of International Health at the School of Public Health, but also the fact that these are intertwined issues. You can't be doing international health and not think about ethics. You can't be doing ethics issues and not think about people around the world. And so fundamentally, they're really two aspects of the same coin. I want to thank Nancy, David, and Mariah for contributing to the discussion. I want to thank all of you for participating, and especially for the school and for the Institute for putting up this show here. And hopefully we recorded it. I hope that you can let others who weren't in the room present, and unfortunately they could not be here, but I hope that the recording will be useful. Thank you very much for your participation.